Good evening. My name is Dr. Chris Goll. Thank you guys for all attending this Zoom conference tonight. I hope it's informative. I've seen a lot of patients with this condition, and I know it afflicts a lot of patients in our community. This is tennis elbow, and most people know it as tennis elbow. The most accurate term for this is actually lateral epicondylgia. It's usually called lateral epicondylitis, and I'll go through that and why that name is not exactly appropriate. And we'll talk about some of the things that can be used to try to get through this condition. Basically, tonight what we'll do is we'll go through that definition that we talked about. We'll talk about some of the anatomy that affects the elbow and the use of the upper extremity. We'll take a look at what causes the disease and what we think is going on at the macro level and the micro level. Go through what I go through when I meet a patient and we talk about how we get to the diagnosis, make sure we're talking about the right diagnosis because there are a number of things that can mimic this. We'll talk about some treatment options, and then after you get through this, how you get back to life and hopefully not have to go through it multiple times. So I call it lateral epicondyle, not really itis. It really isn't an itis, and the itis suffix we typically use to denote an inflammatory condition. And the assumption in this is that it must be caused by some sort of inflammation, and patients use anti-inflammatories. Interestingly, when we do a microscopic analysis of the tissue in this area, we find out that there really are not very many inflammatory cells, and that's different than a lot of other conditions where inflammatory cells become the preponderance of the cells. In this condition, they're more degenerative cells, and we'll go through that a little bit more in a moment. Let's talk about the anatomy of lateral epicondylitis or epicondylgia or tennis elbow, however we'd like to discuss it. I think one of the most important things to realize about this condition is it is not an injury that involves the elbow muscles per se. It is in fact more of a condition that involves the wrist muscles. And specifically, it's the wrist and hand muscles that are used in wrist extension. And so that would be the motion where if you had your arm out in front of you and your palm was facing down, it's that motion when you pull your wrist back. Those muscles originate on this little prominence of bone that you can feel on the outside of your elbow. That prominence of bone is part of the humerus, and it's called the lateral epicondyle. Its purpose is to be the anchor point for the muscles that run down the back of the forearm, and they attach to the back of the hand, and they attach to what we call the dorsal side of the fingers. And when these muscles fire, they pull the wrist back and they pull the fingers back. And it gets its name tennis elbow for two reasons. One, tennis players get it a lot, and probably if it comes about from the backhand, where you can imagine if you're doing a backhand and you cock your wrist in that forceful motion, that you're going to put extra stress through these muscles. Well, the area, the region that is most problematic is where the red muscle fibers become the white tendon fibers, and then those grow into bone. And that's where this injury occurs. It isn't a frank tear where we need to go in and sew something back together. And you can think of it as more of a partial tear or an overstretching of these fibers within the tendon. So we've got some torn fibers that are going to need to heal. If we look now at the microscopic anatomy, on the left is basically the way a tendon is made up. You've got a big tendon, and then there are sub-intertendon portions, and then these become fibers. And in a normal healthy tendon, you could kind of see these as being straight aligned. And then in the diseased or abnormal version of this, you've got these kind of torn, twisted, tangled fibers that aren't healthy and aren't normal appearing. And we'll see that again in this microscopic slide, where on the left-hand side, you've got nice straight tendinous fibers. And in the disease condition on the right-hand side, you see disease tissue with tangled fibers. And on the histology, the name for this is angiofibroblastic hyperplasia, which is not an important term to know, but it's a hallmark feature that we see in these torn and injured tendon fibers. So this is really more accurately called a tendinosis versus a tendinitis. It's abnormality within the tendon. We think it's degenerative somewhat. This is not a condition that we typically see in the teens and 20s, but it's very common in the 30s, 40s, 50s, 60s. So there is a component of this that's activity, and there's a component of this that's almost just a rite of passage through life. So I tell patients this a lot. People say, you know, why do I have tennis elbow? I don't play tennis. Well, the majority of the people that I see with tennis elbow or lateral epicondylitis or lateral epicondylgia do not play tennis. They've never played tennis. They don't own a tennis racket. I get a lot of golfers. I get a lot of people that don't have a job at all. I have folks that work as secretaries, shipping. It really doesn't matter. Almost anybody can get lateral epicondylitis, or on the inside of the elbow, medial epicondylitis. And it almost affects everybody at some point in life, that you'll get some twinge in these fibers. And some people it's severe and it lasts for months and months, and other people it's a couple week passage, but it's very common. And I want to try to convey that to patients, that most everybody's going to get this, and it didn't come necessarily from something you did. Tennis is a good way to get it, though. About 50% of all tennis players will report having tennis elbow at one point or another. Of all the injuries that golfers get, tennis elbow is the most common injury. When we look at tennis, if we're going to talk a little bit about tennis, there are some things that we think may be contributors. And I have had a number of patients who have played tennis for a long time. They went to their pro, they tried a new racket, they got new strings. Heavy racket, stiffer strings. As their game gets better, they think they need to upgrade their racket, upgrade their strings to try to get either a different play on the ball, and suddenly they now have an elbow problem that they haven't had before. We'll see this in an overuse condition, sometimes in factory workers. Some people, it's a particular motion that aggravates it, and most other motions don't bother it. But there are certainly some vocational things that are contributory, but there's a large piece of this that is just nature, and it happens, and people can get through it with some help. Females and males get this pretty much evenly at any time. 1 to 3% of the population is suffering with this. More common in folks 30 to 55. The dominant arm is more commonly affected than the non-dominant arm, but I will tell you that it's not by much. I see a lot of people with their non-dominant arm that is affected, and patients often question that, you know, why this isn't my dominant arm? Why am I getting problems in my non-dominant arm? And the analogy that I use to explain to people why their non-dominant arm suffers so much is that life is somewhat like going through the salad bar. Your non-dominant arm is holding the big heavy plate so that your dominant hand and your dominant arm is free to lift the cherry tomatoes and the olives and the lightweight things. And that's really how life works with our both of our upper extremities, is that our non-dominant arm frequently is used for the heavy lifting, or to be the brace or the vise to hold on to an object, so that our dominant hand is free to do the fine motor things. So when patients come to the office, and they typically, the complaint on the intake sheet is elbow pain. We need to get down to the diagnosis, because there are a lot of structures within the elbow. Any of them can be the perpetrator of the problem. And so I want to try to make sure that we accurately diagnose the condition and make sure that we're focusing our efforts on repairing or healing the tissues that are most bothersome. I do like to get x-rays. This is a soft tissue problem, lateral epicondylitis, but I like to get an x-ray of the elbow because I don't want to miss anything. And frequently what we'll see is some bony osteophytes or some spurs. Occasionally I have found other abnormalities, even including bone cancers. They are not typically very common at all in this area, but getting that elbow x-ray, I think, helps us analyze a lot of the structures, just make sure that we're not talking about a lot of arthritis or other skeletal problems, and we can focus on the soft tissue component. MRI is frequently ordered by folks before they get referred to me. So the patients will see their primary care doctor, or they'll see another doctor, and they say, oh, look, you got an elbow pain, let's get an MRI. In general, they are not that helpful. And I sort of tease patients. If you tell me the name of the radiologist and you have elbow pain, I'll tell you what the MRI is going to say. They're very typical findings. They usually show some increased fluid signal at the lateral epicondyle where the fibers insert here. The report will usually read partial tearing of the common extensor origin, or it'll say complete tearing of the common extensor origin. These are the muscles that attach there. And we expect to see some increased fluid there. I think MRIs are very helpful in the shoulder. I think they're very helpful in the knee. In some of these structures around the elbow, they're helpful, but I think it's less helpful in lateral epicondylitis and medial epicondylitis. So I reserve those for cases that I think are not as clear cut. The most important thing really is the history and the physical. So when I take a good history and we'll talk to the patient for a good amount of time and say, when did this start and how did it start? And the most frequent answer when people say, when I ask, how did it start, is they say, I have no idea. My elbow started hurting. Next thing I knew, it's been 3 months and it's still hurting. So I came to get this examined. The physical exam is helpful. And there are some characteristic maneuvers that I do that I think are helpful in making the diagnosis. I'll show this slide, and then if you can kind of see in the small video, basically what we do is ask the patient to forcefully extend their wrists and extend their fingers, and they do that against my resistance. So patient will hold their arm out, palm facing the floor, and I say, all right, don't let me push your fingers down. And as I push down here, you have to fire this muscle, the muscle that pulls the wrist up and pulls the fingers back. And it's just this sharp pain, and it's so indicative of this problem, and then pressure right over the lateral epicondyle reproduces the pain that people have been suffering with for weeks, if not months, and sometimes even years. So that diagnosis is pretty clear and easy to make. There are some other structures. There's a nerve that passes in this area called the radial nerve, and it can also elicit symptoms with these tests. So I'll do some things to kind of tease out the difference between radial tunnel syndrome and lateral epicondylgia. But physical exam really is the key to making the diagnosis. Here's another picture of some of that physical exam, and it's that the muscle, the most specific muscle that gets reported when we talk about lateral epicondylitis is called the ECRB, and that stands for extensor carpi radialis brevis. It's really a conjoined tendon. So there are multiple muscles that come together into this tendon. So it's not just the ECRB, although that's the one that gets talked about the most in the literature. So as the wrist is forcefully extended, that reproduces pain. Patients report that tight grip really bothers it. I have a lot of business folks and sales folks that travel around, and every time they shake hands in a meeting, they get this reproduction of the pain at their elbow, and that's quite common. Sometimes I can just push down on the middle finger and that reproduces the pain. All right, so when we talk about treatments, there's a whole lot of treatments that don't work. And when I say they don't work, what I mean is they have not been shown to work any better than doing nothing at all or placebo. And the list is extensive. And I joke about it when I meet patients. I say, okay, here's the things that don't work: surgery, cortisone shots, physical therapy, occupational therapy, red lights, lasers, ultrasound, acupuncture, E-stim, A-stim, anti-inflammatories, topical anti-inflammatories, elbow pads, elbow straps, timing copper, the rubber bar on the internet, hot packs, cold packs, K-tape, chiropractor, TENS unit, magnets. All of these things have not been shown to work better than doing nothing at all. And I've gone through that list 1,000 times at least, and it just flies off my tongue, because those are the things that we keep trying, and patients come in, well, I did occupational therapy, it didn't work. I've had 3 cortisone shots, it didn't work. I take anti-inflammatories, it doesn't work. I know they don't work. I've had this condition. At 10 months, I was the same as I was at a week. By a year, it's gone. The reality is, what this condition needs more than anything is a lot of patience and some understanding of the anatomy so that you don't keep re-injuring it. Over 90% of patients with lateral epicondylitis will be better by a year regardless of treatment. The exception to that is if you get cortisone shots. And 1 cortisone shot is probably not the end of the world, but multiple cortisone shots have been shown to be worse than getting no shot at all, equivalent or nearly or slightly worse than getting a placebo injection of saline. So cortisone shots are a mainstay of treatment for much of what I do in hand and upper extremity specialty. But in this particular condition, what we find is that the cortisone can weaken some of those fibers, and it makes the healing take longer, and it makes the healing less complete when it does happen. So the top 3 things that cures lateral epicondylitis is patience, more patience, and more patience. It is a very slow condition to get better, and any doctor that tells patients, yeah, this should be better in a couple of weeks, hasn't had it before or hasn't researched it much, because it does take a long time. Understanding what works, what motions are bad and what motions are not as bothersome is critical. And I have found, and there's some good literature support, that wearing a rigid wrist brace helps. One of the things, the last things I mentioned on this column on things that cure is whatever the last thing your friend did before theirs finally got better. Because I have a lot of patients that come in and they are adamant that their ultrasound made them better, or their elbow pad made them better, or their magnets made them better, or their friend better. And the reality is these people were going to get better anyway. And this just happened to be the last thing they did before they got better. So they attribute their success to that last thing. But the research shows that if you essentially do nothing except understand the anatomy, that over 90% of this is gone in a year, which is a long time. And I would be happy to come up with a faster treatment. And if I can, I will, but nobody has yet. So we'll keep working on it. This slide is taken out of a study of a lot of different things that were studied. And basically what it supports is this idea that everything works and nothing works. They all work about the same, or they don't work about the same. Most people are going to get better over about a year, regardless of what you try. So I'll go through some of the treatments because these are the ones that people ask me about, and at least I'll explain what they are and what we know about why we think that, or why people think they work. The 10X is a relatively new one. It's an in-office procedure. It's fairly expensive, but the concept is similar to what we do with cataracts, where you insert a probe into the region where you have this degenerative tissue, and then this high energy is used to break up that diseased tissue, and then you rinse that out and remove it. And the thought is that this improves people's outcomes. Well, the reality is it has not been shown to be any better than placebo. So it's not used in my practice, and I'm not familiar with anybody using it in this area. So I'm not a fan. Some other pictures of that, and they all have a study. Everything will have a study that shows that it works. This is a study over 3 years with only 20 patients in it. 20 patients in any study is not a study. That's a collection of people that you happen to know. You have 20 friends, but that does not constitute a legitimate study. Arthroscopy is used in the elbow, and I've got some very talented arthroscopists in my group. Our sports medicine team are very good at arthroscopy. It has not been shown to be particularly beneficial in lateral epicondylitis. The concept is basically very similar to the way 10X would work, is you somehow get into the elbow, you find this diseased tissue, and you burr it out or debride it out, and then hope to stimulate some healing. Frequently that's done where the bone is actually debrided a little bit to get some bleeding tissue, and the thought is, well, that may stimulate some healing. I have found that by the time patients live with the condition, then see a doctor, then live with it, then go to surgery, then recover from surgery, they're at about a year, and a lot of them are better. But I will tell you, I have a fair number of patients that my longest standing lateral epicondylitis patients have had either an open surgery or arthroscopic surgery, and they're not getting better. And something either happens during the surgery or the tissue gets weakened. So I'm not a big fan of surgery for lateral epicondylitis. I think it probably has a role. And I think in the right hands, there might be a way that you may be able to stimulate some healing or engross some tissue. It's just not frequently used in my practice. Open surgery, and again, this is very similar. You're debriding the tissue that you think is the diseased tissue. And what makes this challenging is that there's no blinking red light when you go in arthroscopically or you go in open. there's nothing obvious about what's the diseased tissue and what's the normal tissue. So you get in there, you look at it, you pick at it a little bit with a tool called a rongeur. Sometimes you'll put an anchor in the lateral epicondyle and sew the tissue back, and you feel like you're doing this great repair. But the reality is there's no good science that this works any better than doing nothing at all. We talked a little bit about cortisone injections. Not a fan. This was the lead article in the Journal of the American Medical Association, which is probably the biggest medical journal on the planet. And it basically, they looked at cortisone injections, therapy, and a portion in there on bracing. And they found that the cortisone injection group did the worst out of all the groups. So I don't offer cortisone injections for lateral epicondylitis. I think the exception occasionally is a patient comes in, they've saved their whole life for a trip to Ireland, they're going to go play golf, they need a month worth of relief. Cortisone shot might provide that, but they get it with the clear understanding that this very well may set you back and make you suffer longer in the long run. I see this probably most pronounced in my patients that either a primary care doctor or somebody who's trying to do good and provide help to their patient just gives repeated cortisone injections, and that really weakens the tissue and inhibits its ability to ever be able to heal strongly. And here are a lot of gizmos and gadgets that people try. I remember there was it was either a hand surgeon or an upper extremity specialist who invented this rubber bar, and I don't know what it sells for, but you buy this rubber bar and you do these twisting exercises. There's no evidence that that thing works, and I have a number of patients that have tried it and they are much worse than they were before they started doing that. So repetitive use of the muscle that we know is damaged doesn't seem to improve it. It's not a weak muscle, it's a weak tendon attachment. And while this thing is injured and you try to continually stress it, you just run yourself further down the rabbit hole. Ultrasound, electrotherapy, shockwave, shortwave, lasers, none of this seems to make any difference beyond the placebo. So again, 90% of people are going to be better within a year, regardless of treatment, except if you get a cortisone shot. The cortisone shot group tended to do worse. So this, and I give this out as a handout when I see patients, so we go through these things. On the right-hand side, in the red, are the don'ts. So these are the things that we know makes this more bothersome. The thing that really bothers people is when they lift things and their palm is face down. So picking up their big Yeti cup out of their console, pulling a garbage bag out of a garbage can, pulling files out of a drawer, lifting a laptop bag up into the overhead compartment, anything where there's weight in the hand and the hand's being pulled down, you're countering that force, and that force is going right into the muscle and a tendon attachment at the lateral epicondyle. And it just keeps ripping and ripping and ripping these fibers, and they just don't get a chance to heal. If you have to lift something, and I'll demonstrate this when I see patients in the office, when we do the physical exam, is if I push on a patient and their palm is facing down and they're firing the wrist extensors, sharp, immediate pain, very weak. As soon as I turn the hand over, I can push twice as hard and it doesn't reproduce the pain on the outside of the elbow. So if you have to use the right side or your affected side to lift, what you want to do is do that in a palm up direction. Try to share that load with two hands. Pushing is better than pulling, and keeping the elbow in closer to the body. So lifting palm up, elbow near the body is going to be way more effective and way less painful than lifting palm down and far away from the body. One of the things that repeatedly has been shown in multiple studies to make people's suffering duration shorter is to wear a large, rigid, durable wrist brace. Not an elbow brace, a wrist brace. So the brace that I like, and I've been through a lot of them, and the reason I like this one is basically it's durable enough to last, but it goes from the middle of the hand to the upper forearm. So it doesn't go above the elbow. It doesn't wrap around the elbow. It's not one of those Velcro elbow straps with the little balloon in it. It's a wrist brace. And what it does is it keeps you from using the wrist, lets you still use the fingers, lets you still rotate, lets you still use the elbow, but the wrist is being immobilized. And again, these are wrist muscles that are injured. So if we immobilize the wrist, this gets a break and those fibers can heal. And I tell patients, if you come back with a tan line and a brace that stinks, you'll have a better elbow. One of the potential treatments that I think does show some promise, and I've had some success with in patients that come in and let's say their primary care doctor has given them, 4, 5, 6 cortisone injections. They really have shown no improvement over a long period of time, maybe 1 year, 2 years, 3 years, is using platelet-rich plasma, PRP, or what we call autologous conditioned plasma, ACP. And they're similar, but basically the concept is draw some blood, spin that down in the centrifuge, and you take the plasma portion, which is this kind of golden portion over on the left-hand side of the screen, and inject that into the area. And we think it works in a couple of ways. One, just the mechanical action of putting the needle in there. So you take the needle and I kind of pepper it in there a little bit, try to create a little local trauma to try to stimulate some healing. When there is blood product outside of the vessels, that's an abnormal condition in your body. And we think that that triggers some of the signal pathways to stimulate healing. So this condition never really has a big event that causes bleeding within the tissues and starts triggering these signal pathways the way a broken arm does or a cut tendon does. So this sort of simulates that, and we think it puts in place some of the proteins which are important for rebuilding some of this tissue. So I've had some success with this. My frustration is that about 5 or 10 years ago, insurance stopped paying for it. The price to do that with us is somewhere, I want to say around $500 for an injection. And a lot of it is just the expense of the equipment to separate the blood. But that's an option that I have used with some success in some tough conditions. I have not had any success or real trials that I've seen that show stem cells or benefit. I think in that condition, they may help, but the cost is a lot more. And so I'm not sure that we're there to warrant a couple $1,000 expense for the amount of improvement we may see. Lateral epicondylitis is going to get better. Typically 6 to 12 months, it's better. And the real question is, well, how do I not have this happen over and over again? How can I strengthen these muscles or strengthen these tendons? And the reality is people don't usually get this over and over and over again. And the real reason that I believe that doesn't happen is that once you've had this once, you recognize it. And so the next time you go do something and you go pick something up this way, or you go start a project where you're doing something, and you start feeling this pain out here, you'll stop and you'll say, okay, I got to change my position. I got to go palm up. I got to get around this. I got to use 2 hands. And you don't get as far down that injury pathway that you got the first time. And so we don't typically see this happen over and over in people's life. They may get it on the other side, and then a couple of years later, it comes back on one side, but that isn't the norm. And a lot of it's just positioning your arms, get yourself in the best position you can get into. This top row of pictures is kind of the awkward positions that people do things in. So they're out of desktop, they're reaching, a lot of extension, get up closer to the desk, figure out how to get in there so that your hands are more comfortable, swinging the hammer. Don't go into this hyperextended position. Again, a lot of it's positioning, get closer, get in a better position. Don't lift a heavy bottle from the top, get it from the side if you can. And that stuff can make a big difference so that you don't live with this for a long time and live with it repeatedly. That is it for lateral epicondylitis, lateral epicondylgia, tennis elbow, whatever you'd like to call it. I hope it's been helpful. I enjoy seeing patients in the office and trying to teach them these things, both about both elbow problems as well as wrist and hand problems. This is really my passion in life, and I love to talk to patients and kind of go through slides like this when I see folks in the office. So if I can help, I'd be happy to. If there are any questions, but otherwise, thank you very much for your time tonight. There is, and I've unfortunately had both, and I will tell you that the medial side I think is harder to treat. The biggest reason, and the treatment really is very much the same. The prognosis is also good. I just think it takes longer. The medial epicondyle anatomically is larger. The muscles that attach to the medial epicondyle are larger. Those are your wrist flexors, your finger flexors, and for that reason, primarily, I think it takes longer to heal. I also think it's a little harder to avoid use of the flexors than it is the extensors. And so for that reason, I typically tell patients medial epicondylitis 1.5 years, lateral epicondylitis 1 year. And there's a lot of flexibility in that timeline, but in general, yeah, good question. Medial epicondylitis seems a little tougher. It probably doesn't matter. I think there's probably some, if we're going to say if there's benefit or not, the benefit could be you massage it, you may stimulate a little bit of blood flow there. If I were to choose heat, if I were to choose one or the other, I'd choose heat over ice for the same reason. It's not likely to make it any worse. And if a little gentle massage on there with some icy hot or something like that makes it feel better, there's no good reason to think it's harming in any way. It's one of those things that's an easy try, and if it helps, do it. My normal regimen is do one. I do one, I give it a month. I think it takes about a month to really metabolize a bad bruise, and that's kind of what we're doing, is creating blood outside the soft tissues. So I do a month and see people back and see if they're getting some improvement, that shows some healing. I don't typically recommend people need to keep doing them over and over. I've had patients where they say, you know what, I'm doing 3. I've got the money, I want to do it, and we'll do them, and I'll space them out about a month. But the hope is that one stimulates some healing.